So we are starting with the smile surgery. Can you see the data? Here we are having a diameter of the cap as 7.2, the thickness of the flap as of the cap as 120. Side cut angle we will be doing at 90 degrees, that means superiorly. Lenticule will be of 6.2 millimeters, and what we are going to do in this particular case, the patient has a power of -9 with 0.75 SIL. So the total residual stromal thickness is 265. She had a started thickness of 529. So this is the settings that we are going to have. Come, niche lao. We are going to attach the cone. Either just come here. Yes, so she is a pleasant young lady of 36 years. Come here. ये लगाओ. No, थोड़ा पीछे करो. Go back.
The PIP has to change.
इसको लगाओ ना. आप, sister, you put this ना. पीछे हो जाओ. Just go back. Okay, so this we are adding on to the suction. Can you see this? This has been added on to the suction. This is the patient interface, as you can see. So, इधर देखो. Focus on this. Okay, so this is a patient interface which is at the limbus. Sorry. Yeah.
Mahipal, the projection here is a little small. So we need to cover a big audience. So if we ask the people there to project on the screen, because we can't see
Make it full screen.
Make it full screen.
on the screen only, don't make it a PIP.
Yeah.
Make it a full screen. Yeah.
So can you see this? We have put it on the. Okay.
Sir, right now, sir, right now,
Yeah.
whatever you are showing is coming in a PIP. So can you put it on the big screen, please?
Audio visual, please put it on the big
Put
screen.
it on the big screen. Yeah.
Yes, sir, now
Karo.
it is perfect.
Okay. So we just putting in the speculum. Okay. Give me this thing. So I'll just wet the cornea a little bit. Are you getting the microscope view or the external camera now? Achha. Okay, so anyway, you give the microscope view, I think. So anyway, the eye we are taking below the patient interface. Can you see this white light? बेटे ऊपर की light बंद कर दो. Can you see this green blinking light? Can you see that? Okay. So I am going to raise the bed of the patient. Bete, this white cone is going to touch your eye. I have to just tell the patient that the patient has to keep looking at the green blinking light. Look straight. Just touching the cornea. Don't move now. Suction on. There is a very small thread. It's not going to come in the way. Ready? Ab laser fire kar raha hai. Don't move. 22 seconds. So the laser is firing. You can see the green light is about to disappear now. Bete 15 seconds more. This is the side cut that has happened after the top cut. After the posterior of the lenticule. This is the anterior of the lenticule, and this is a 3 millimeter. This is much bigger than 3 millimeter. Is it 4? Anyway, I normally have a 3 millimeter. I think it's 4 millimeter they kept, but anyway, it doesn't matter. So the machine says safe distance. So this is at 90 degrees, and you can see that now I have the microscope automatically comes on. Look straight, please. Can you see a diffuse light? Okay, give me that. So what I am going to use is essentially going into the entry cut. So you see I am going into the entry cut. Now this is the movement. Ek drop dal dijiye. I have to just go up to go into the anterior phase. Okay. So this is anterior to the lenticule. Okay. And now I will go below the lenticule. So this is below the lenticule. So you can see here, this is called as the stop sign. Can you see there is a resistance here, Namrata?
Yes, sir.
So this is the stop sign. This is the described by Gitansha et al. This is the meniscus sign where you can see a meniscus which is forming. Okay, and then there is, look straight. And then there is a drop, and then that was described by you people, and then Tityal and all. and then you will also have a white ring sign. Look straight up. So we are going into the anterior of the lenticule. It doesn't matter, you can go anywhere, but when you are going into the posterior of the lenticule, you need, better light ko dekho, look into the light. When you go into the lenticule, posterior of the lenticule, dena mujhe, give me that first one. When you go into the posterior of the lenticule, you should not disengage totally from one side because you get a taco effect. So this is the posterior of the lenticule that I have again separated because ek drop dal dijiyega. So as you go in, you see now what I will do is that I will just go down at the inferior part, go outside the lenticule edge, doesn't matter, and then I will slowly, gently dissect. So you can see I am going like this, but I am not disengaging right to the top. And now similarly, I will go here and I will disengage from the bottom, come towards the top here, and now I have to disengage. So this is being disengaged, and from the other side also I will now disengage. So you can see now it's a floating lenticule. You can hydro dissect it also, but I use this forceps to kind of just hold it. There's a small tag here, take it out, and you can spread it out. Give me just a McPherson or something, anything, forceps. You can just spread it, though it's not needed to just spread it on top of the cornea to see that it's a complete lenticule. So you can see that's a complete lenticule that has been removed, and that's about give me a wash. I just tend to, ये freeze हो रहा है. Are you seeing it properly, Namrata?
Yes, sir.
Okay, so we
It's visible very nicely, Dr.
Yeah,
Agarwal.
okay.
Beautifully done.
So we just
But can you give us some tips to avoid such a loss?
Okay. So, ek McPherson, I'll just give you, can we have the light on because I'm done with the surgery. There's a free epithelium here, so I'll just take it out because this causes unnecessary irritation to the patient. Drops dal dijiye antibiotic. Okay, so that's the end of the surgery. Okay, so the tips that you have to do is that the first thing is that the patient should not be apprehensive. The anesthetic should be proper, and the patient has to be told that the patient has to look at a blinking green light. Now, often when the green light disappears, when the first pass is coming, the patient starts to search for the green light. So I didn't televise that, but the patient was told beforehand that when the green light disappears, the patient should not bother and should not start searching for the green light. So that is the other thing. You should not have too much of fluid. That is something very important. Though a dry cornea is going to cause cold spots, so you should have just a little adequate moistening of the cornea and not too much of this thing. The speculum should be adequate to open the eyelid so that there isn't any undue pressure on that, and the patient's head can be held slightly by you so that the patient doesn't give a jerky movement. So these are a couple of things that we would wish to say as regards the loss of suction. And the other thing is, if the person has a prominent nose, you should actually turn the head a little bit so that the cone comes properly. And then for the centering, you should not press it totally or jam it on the eye immediately. You should just have a soft touch. And when you have about 80%, 70, 80, 90% of the applanation that is happening, then you press the suction so that then it takes 100% suction on the area which is there for the applanation. So these are a couple of these.
I also think one more thing which could be done is, sometimes a person is not docking it fast, bringing it slowly down, then even the last minute, just one more drop of saline and then again drying up the furnace would be better. The dry spots will not be there at all.
Yeah, so basically it depends how fast you are and you know what it is. So right before I start to bring it down, I just wet the cornea without putting a drop. Actually, it's a small liquid film that I put so that it becomes wet, and that is what is important, because dry spots are something where you will get uncut areas. So the adequate fluid has to be there, not too much, not too less. Sorry, if your question, I didn't get the last part, but if the question was on cyclotorsion compensation, I mark the corneas whenever the cylinder is more than 1.5 diopters, and the reticule needs to be matched on that under the microscope at that particular time, and you can taught the head of the patient to get zero torsion. Now all these machines which are there, whether it is the Visumax 800 or it is the Silk machine, etc., they all have the ability to see and to, so IOL Master 700 with the Visumax 800 is tied to look at the cyclotorsion compensation which is there and centration. So there are two things which are important. You can't even change it in the Visumax 500 on the centration, but the new machine allows you to center also, as also it allows you to do the cyclotorsion compensation. But as things stand today, if I am not centered, then I will release the suction and redock that is there, and for the cyclotorsion the mark is there, the ink mark through the infrared ink, and you can rotate the patient interface to get on for cyclotorsion compensation. But I am getting excellent results with this cyclotorsion compensation on the mark that you do for the patients which is there. But obviously an automatic registration of the iris with cyclotorsion compensation would be something that is always desirable.
Thank you, Dr. Mahipal. Wonderful surgery. Any questions?
What is the upper limit of cylinder where you would not do a smile when you do femto contour?
Femto contour. The question is for Titial or for me? So it is going to be very, very subjective. If you are doing a marking, I have done even 4 or 5 cylinder for that, and we have got excellent results. There are some people who would prefer to do a LASIK or a contoura because that is more appropriate as regards the accuracy of the cyclotorsion compensation, but all new machines are allowing you to get good cyclotorsion compensation now. So this myth about, so see, basically it's the Mullrine formula that is working. It's no different for an excimer burn versus a lenticule removal. The Mullrine formula is going to be the same. So that's the results are going, as long as your cyclotorsion compensation is good, the results are going to be fantastic.